Thank you very much, Bruce, and thank you, PBB, for having us here. Thank you to the participants as well. I'm going to be speaking in the realm of post-disaster intervention, and my talk will be slightly different in that the focus is not just on research around 9/11, but has been about research that has been conducted since 9/11 in the field of disasters, and you'll see why in a minute. I myself am an educational specialist at the National Center for PTSD and a Associate Director of Terrorism and Disaster Branches at the National Center for Child Traumatic Stress. That involves not so much direct research, but really working closely with researchers as well as providers and practitioners to integrate what we know about disasters, what we know about responses, as well as what we know about intervention. So in my talk today, I'll be covering a number of different topics, such as assessment and screening, what we know about different time frames of intervention across from the first 2 weeks to 3 months onward, and speaking a little bit about special populations such as children and adolescents and communities and individual resilience, ethnocultural considerations, and then finally talk about how the field has come together to take a look at disaster intervention based on consensus guidelines because of where we are. So how do we know how to respond following disasters? When I first started this work at the National Center for PTSD in 1999, SAMHSA, the Substance Abuse Mental Health Association, came to us and said, can you help us understand from what the literature says how to intervene after disasters? They were administering crisis counseling programs for FEMA after disasters. And they asked us to look at the literature. We said that's very easy because there isn't a lot. So over the course of the last 10, 12 years, what we've done is try to take a look at knowledge from a number of different areas, starting with disaster research, but also looking at the broader field of trauma research and extrapolating from that because there's much more research in different types of traumas. We also took a look at the experience of providers under the great leadership of Fran Norris. We conducted a number of case studies across different disaster types and collated that information. And from that work, Fran set up a kind of a groundbreaking program evaluation of the crisis counseling program over the last 5 years or so, as well as looking at customer feedback. And I want to touch on expert consensus. What we've done, because there was so little direct disaster research to look at, when we started this work, we set up a number of consensus conferences where we would have researchers from the field of trauma research as well as disaster research come together with practitioners who've been working in the field. And we set up a number of these consensus conferences where we would ask them questions. What would you do under these circumstances? What would you recommend? And brought together their guidance to help us both design interventions that I'll be talking about, as well as inform policy, inform future research, and get a kind of a framework for people intervening after disasters. One example of that is a panel on ongoing threat that we conducted. And we had researchers and practitioners from around the world come together and take a look at the literature base. And as we were sitting in that panel, Stephen Hopwell, who's a very, very well-known researcher in the field, said, you know, it seems to me that as we've looked at this broad range of research across those disasters and different types of threats, what comes clear is that there are 5 principles that seem to go across different disaster types and different trauma types that are related to better recovery. And those principles are helping people to establish a sense of safety, both objective physical safety, but also a psychological sense of safety, helping to calm people in different circumstances, getting people connected with social resources, and promoting a sense of both self and community efficacy, which basically means that no matter what a person is going through, they feel that they have the resources to cope with it, or the community feels that it has the resources to cope with it. And finally, a sense of hope, which can be based on both a sense of, for some people it's a sense of spirituality or connection to the divine. For some people it's a sense of connection to their community, both small and larger, where they basically feel that things are going to work out as best as they possibly can. So with that framework in mind, a number of interventions have been developed and a number of guidelines have been developed, both for individual intervention after disasters, but also a broader public health model for intervening, with a number of recommendations for each of these 5 principles. So I want to briefly talk about what we found in the realm of research now, taking a look at the area of assessment and screening. And why do you think this might be important? Because we need to know, as Yuval and Roxy have pointed out, how we should target our resources. How do we focus in when you have the chaos post-disaster? What do you need to be doing? And in this realm, we have found from looking at the literature that it's very difficult to make cross-disaster comparisons. A lot of people doing the work have said we need to start to normalize and bring together instruments that are used across different disasters so we can compare better. And some of the work that we found very interesting in the last 10 years have to do with describing the recipients who use services. Some of the work right here in New York City with Project Liberty, where they were able to identify which types of people use services and benefited from services. And we've been able to do some of that from Fran Norris's work with the crisis counseling program as well. We've also seen groundbreaking work in terms of utilization of services over time, both with the crisis counseling program in our country, but also in other countries. Bruin and his colleagues, after the London bombings, were able to tell us that if you set up what they call a screen and treat program, you're often able to identify many more people for treatment if you do an outreach effort and try to call people, ask simple questions, simple screening, and identify people who might be having more difficulty. What we found from that was very interesting is that the numbers participating in the post-disaster treatment are often very small relative to the numbers screened. So a person might be screened, they might be recommended for treatment, but it's often very difficult to get people in, particularly in the early phases. It's very important for us to know that as we design our disaster program. When I was taking a look at some of the broader trauma research for cognitive behavioral interventions, I was struck by a number of studies that indicated in the methods section that people often don't present for treatment until an average of about 10 years after the event. So little pieces of information like this, and that the information that we're gathering from some of these screen and treat programs might suggest to us that in terms of policy, we might want to have programs available over time, so a longer range than what we have right now. We also have found that those who were screened who did attend treatment showed a substantial reduction in symptoms. So from that perspective, we know that it's valuable to get people into treatment. We just have to figure out how and when. There's also been some interesting work with, again, Fran Norris. I'll mention her name a lot because she's done a lot of great work in this field, but describing an assessment and referral tool that seems to be helpful at identifying the stress and functioning that would give us good cutoff scores for people who might be good candidates for treatment. So moving into the treatment research, there's been a lot of look at timelines after disasters and which interventions are most appropriate at which time. What we know from looking at primarily consensus efforts and case studies is that the primary goals in the first 2 weeks have been recommended to be really to promote these 5 principles that I spoke about, promoting safety, attending to people's basic and practical needs, helping to enhance their coping in an informal type of way where you give them suggestions and talk with them about what seems to be related to recovery, helping to stabilize people and connect them with additional resources, both social and practical. So one good example of this in an effort that I've worked in is the psychological first aid model. This psychological first aid has been coined for decades. Bob Pynus and Bev Raphael have talked about this for a while, but in the last 10 years or so, the National Center for PTSD and National Child Traumatic Stress Network have one example of a model, a field guide, where we didn't try to reinvent the wheel and create this brand new intervention, but what we tried to do was look at the evidence base about what seems to be helpful, try to operationalize some of these principles that people have talked about but not fully operationalized, try to make it something that can be used across all developmental age range, and have information in there about cultural alerts as well as what to do, what not to do. And I'll talk about that in a minute. Part of why the move towards psychological first aid got started was that in the first 2 weeks, there was a big question right around the turn of the century about the use of a debriefing model, which is generally has been used with first responder populations, but it's a group intervention that involves having people sit down and talk about what happened, their reactions, their thoughts, their feelings, and a little bit of stress management. And what was happening around 9/11 is that a number of research studies were showing that it was either not effective in the long run to reduce long-term problems, or for a few individuals could actually be detrimental. So in the first 2 weeks, the methods of critical incident stress debriefing and other debriefings have been generally not advised. And in the same way, cognitive behavioral interventions and EMDR, which is a type of cognitive behavioral intervention, also might be contraindicated in that they both encourage disclosure of thoughts and feelings and processing of their emotions, which take energy and resources and might interrupt a sort of a downtime that people need. When we brought the consensus conference together, we asked specifically of the researchers and practitioners, why do you think that a debriefing model might not be the best model in the early phases after a disaster? And there were a number of different answers to that. One is that in the context, it might not be appropriate for primary survivors, or it might not be appropriate in the context of massive chaos and ongoing stress, where people are really just trying to get their needs met. They have a lot on their plate, and to pull them out of that and have them talk in a group like that might not be the best use of their time and resources. Some indication that the timing isn't right for that because of those reasons, and that there might be some avoidant downtime needed for some people. Many of us have experienced that when you have a lot on your plate. You get into this kind of cognitive mode of, I got to get business, I got to get things done, and I don't want to deal with my emotions until later. The format might not be the most effective for education, like stress management education, because it doesn't allow the time for that. And priorities are also a factor in that. What we've seen is that in some communities, people will say, okay, we've got the debriefing, so let's have that be our mental health intervention, and we got that covered. And what really, as you can see from the presentation here, we're going to need a multimodal approach that includes many other types of interventions. And finally, there was a feeling from the experts that it is inappropriate as a model for acutely bereaved individuals as well as certain cultures. Therefore, things like the psychological first aid model have been recommended. In our particular model, the National Center for PTSD and Child Traumatic Stress Network, we included 8 core actions, just to give you an idea of what this includes. It's meant to be a model that's used very flexibly with people, that involves engaging with them, providing safety and comfort for people, particularly those who are bereaved, stabilizing those who need it because they're overly distressed or are kind of dissociated, getting information in a very conversational, casual way that might inform both referral as well as what you do with them, providing some practical assistance in problem solving with people, getting them connected with social support, and giving them some basic information about coping, and finally linking them with collaborative services. It should, if it's done correctly, look different with every single person that you intervene with. For some people, you might be intervening for 5 minutes and getting them hooked into some practical resources. For other people, you might be working with them over time in the shelter, and you have much more time to provide other types of interventions. In the realm of 2 weeks to 3 months out, cognitive behavioral interventions for PTSD and acute stress disorder have the strongest empirical support. It doesn't necessarily mean, as I talk about all this research, it doesn't necessarily mean this is the only thing that works. It just means that these are the things that have the most research support. We, however, feel that even though they have research support, they might not be recommended for routine use with everyone, particularly in the first 3 months, for the reasons that I mentioned before. You have to have more resources to engage in a more formal type of treatment, and to the extent that there's still a sense of threat and that people don't have sufficient resources to engage in this, they're not going to be the right, this isn't going to be the right type of intervention for those people. So we've moved, in working particularly as the crisis counseling program, we moved towards using an empirically supported model, but that's more flexible and modularized with people. What we like about cognitive behavioral intervention informed our work with a model called Skills for Psychological Recovery, which was originally called Secondary Psychological First Aid. But now we call it Skills for Psychological Recovery because there's an emphasis, like in a lot of the cognitive behavioral interventions, an emphasis on building skills for people. It's a model that is based on empirically derived skill sets like prioritizing with people, helping them problem solve, have positive activities, manage their distress, little helpful thinking where you do some cognitive reframing, and help build social connections. But it's meant to be used in a very flexible format. It could be standalone sessions or multiple sessions, which we encourage. And it's meant to build skills for people in a kind of a partnership with the counselor. We found very good outcomes for this in the crisis counseling program across a number of different disasters. In the area of 3 months onward, the research support, again, is primarily in the realm of cognitive behavioral approaches for a wide range of problems, not just PTSD, but the other problems that Yuval and Roxy mentioned, depression, anxiety, that type of thing. But we also know that there's a lot more work needed across the board, across time frames for research in these areas to know which are best tolerated, which factors are the most potent, and which work most quickly for people. Some interesting innovations in this realm involve, particularly post-disaster and post-terrorism, involve some brief telephone interventions that have been done using cognitive behavioral principles, some nice virtual reality strategies with first responders here in New York and in other areas, and some single-session simulations post-earthquake with Bassett and his colleagues and after the Turkey earthquake, some writing exercises that we've seen people doing after after terrorist events, and then some internet-based interventions that have shown very good results with people. With children and adolescents, very much the same picture in terms of immediate phase with support and psych first aid, and in the later phases using CBT interventions, but some innovative work around school-based, family-based interventions for children. It's much harder to get research with children, so the field is smaller. George Bonanno, who was a co-author with us on our paper, also has mentioned some really nice resilience strategies based on his work as interventions that can be adapted post-disaster. And as he says in his work, there's a need for more research in this area because we don't want to just recommend a set of interventions. We know from looking at some of the work that it's more about the flexible use of coping strategies as the need is there. So how to help people be more flexible in the way they use these different types of resilience strategies rather than just applying them in a very straightforward way. I want to quickly mention that there's been some nice work written about community resilience from Fran Morris and Project Liberty here in New York used some of that work in getting communities to work together to build their sense of self-efficacy and their connections with each other. And a lot of work talking about which ethnocultural factors need to be put into place for these interventions to be effective across different cultures. And I don't mean just in different countries. I mean cultures like first responders, children, different cultures that have very different ways of thinking and doing things. And then finally, from all this work, the research, the expert consensus conferences, there have been some guidelines developed in the last few years based on a lot of this work. And what they have in common is some basic principles that talk about being proactive, practical, flexible, really based on what the resources of the community are, promoting these 5 principles that I mentioned, doing no harm by considering human rights, cultural sensitivity, staying updated on the evidence base, and trying to match interventions to not only the information you gather from people and communities, but on the resources that are available. Trying to maximize local participation, resources, and capacities, and integrate programs and resources, using a stepped care approach. What we heard from Yuval and Roxy is that a large percentage of the population is going to be resilient. However, we need to focus on the people who have overcome the problem. So we need to have a stepped care approach where you have a large-scale effort for a number of people and a smaller focused effort for other people. And then finally, very important to know that we need a spectrum of services for people, including basic needs all the way up to treatment, and having outreach, assessment, helping to train local providers in trauma treatment, helping to provide technical assistance, that type of thing. So in summary, we have a number of advances, including clarification of risk, protective and resilience factors, identifying some potential outcome trajectories, and understanding of coping strategies, timing of interventions, different types of adaptations for different groups, how to improve training, and then development of some metrics and methodologies. But we still have a ways to go. we have a hopeful picture here, but we recommend a number of things, including systematic perspective and longitudinal research to help us know what works best when, what works best for people across a number of different factors, using theoretical models to help us be more sensitive and understand what's going on with people, and continuing to evaluate services. This is an area that is very much needed. What you'll find, if you look at the research, when we were looking at this, we had about 500 studies that were focused on effects and resilience factors, and about 50 that were focused on intervention. It's hard to do. So anything that people can do to do program evaluation is very much recommended. And finally, I just want to say that we also need to look at what's acceptable and feasible for communities and recipients. You can recommend a Rolls-Royce model. As my boss, Matt Freeman, always says, there's a Rolls-Royce model, and there's a model that actually is going to fit with the community. And we need to look at how that plays out in different communities and focus on what's needed. So I will stop there.
Well, thank you. Stay here for the question. There are a couple of the last few points you made focus actually nicely on a couple of questions. Vanessa in Anaheim, California, is wondering what we know about how many 9/11 survivors sought help, and particularly among ethnic minorities and low-income groups, and how many agencies reaching out, how many agencies are really making affirmative efforts to reach out to those kinds of constituencies?
That's a very good question. Thank you. You will find, based on some of the efforts with Project Liberty, that they were able to reach a substantial number of individuals. And there were thousands of people who received services. In different sub-communities, the numbers were very different. They had to be very creative at the way they did outreach. So, for instance, the Chinese American community, they had to focus in on primary care settings and doing outreach there because the focus was more on physical health effects. And they found that Project Liberty across the board tried to focus on many different subcultures. They did an excellent job of being creative in that way. And I think outside of Project Liberty, there's been an effort, especially now during the anniversary. There's been a needs assessment that's been done in the last 6 months, and there's been a focus on intervening. There's a program that's been funded to intervene for anniversary reaction. So the message is that there's a substantial portion of the population that received services, that reached out for services, and that were served. For those that received services, there were reductions in symptoms that were shown, and that the long-term and longitudinal work is needed for anniversary action.
One last question, at risk of getting political, and it may be, Yuval and Roxy, that you want to weigh in this one too. Dr. Jackson and the interns at the Manhattan VA say, please comment on the cut to funding to treat 9/11 survivors despite an ongoing need for treatment. Any thoughts on that?
Okay. This is something that I think from a policy point of view, most of the expert consensus conferences focused on, and most of our work with case studies also found that there is a need for some funding longitudinally for the small portion of the population, as you've all mentioned, that are going to have PTSD across time. And so it's challenging because generally after disasters there's a flood of funding and then it drops off over time. And I think for a large percentage of the population that's probably appropriate. But for the smaller percentage, we've made a lot of recommendations to try to have a smaller fund for people longitudinally who can need it, the high-risk population.
Okay, one more. From Alana in Tulsa, what do we know about special needs for those with developmental disabilities and appropriate intervention?
Thanks, Alana. That's a very good question. And what we know is that there is a need for people with developmental disabilities, and that the work, especially the work of the National Child Traumatic Stress Network, is aimed towards trying to discover what the best interventions for those folks are. I know that that the National Center for Child Traumatic Stress has really been focused on how to intervene in hospital settings, in different types of care provider settings for kids with developmental disabilities. And there's a great need to continue to do this research and also fund programs that do this, because there's a need to be creative in the way that you apply these models and work with the family in particular as well as schools, because you're going to see decrements in school functioning as well as family interaction. So thank you for the question.
One more, and then I'm something to ask all of you. Jack in Kerrville, Texas, wonders about the difference between doing psychological triage with victims of natural disaster versus terrorism. What do we know about that?
We know from looking at the effects of natural disasters versus terrorism, as Yuval was saying, is that there are different factors that come into play. So with natural disasters, there could be just as much stress, but it's around things like loss and ongoing factors. In Katrina, for instance, with displacement and that type of thing. With terrorism, there's always the ongoing threat situation that has to be cared for. We know that oftentimes you're not working just with helping people with post-trauma reactions. You're working with people who have ongoing and anticipatory trauma reactions, where they're concerned about what's happening. In one of our expert panels, there was a comment that the security measures in our country over the last 10 years have had a huge impact on public mental health. If all you can imagine what would have happened if there were 20 or 30 other terrorist attacks that were successful, the mental health would definitely be a much larger factor. So in a multimodal way, we have to take into account these different factors that are involved in terrorism.